Hello, everybody. I'm Dr. Aki, an interventional pulmonologist at National Jewish Health, in addition to the founder and co-CEO of EON, in which over the past few weeks, we've really been focusing on what we call essential patient reports and EON Safety Net, which is a mechanism in which the patients who are diverted, who are non-COVID patients, have the ability to be triaged into who needs to be seen immediately versus who needs to be seen sometime in the future, and there's risk of exposure to COVID would be higher than the risk of any type of disease progression. And so I think that many of my colleagues I know have been doing the same with their own practices, where they're going through the patients that they're supposed to be seeing in the office. And right now, I think that the majority of office visits have been diverted. So what we really want to bring to light here, and the reason for us doing these live little briefs is that we want to show you what we think is happening because of the COVID crisis. And the easiest way to pull that up is to look at essential patient curve data, which I'm going to share now. And this is up on our website at eonhealth.com. And you can see that this is a representation of what we call the essential patient curve model. And so back in the end of February is where, at least in my office practice as an interventional pulmonologist, that we started diverting patients from the outpatient practice and stating that, at least when it comes to lung cancer screening, annuals and baselines will likely be pushed to the right, in addition to patients who have a very low risk pulmonary nodule or an annual follow-up could be pushed to the right. Now, there is data that states that increased morbidity and mortality for higher risk patients could occur, in which an upstaging may occur if that patient does not get scanned or have a diagnostic procedure. So there are patients who need diagnosis now. And while I'm talking about mostly pulmonary nodule, because that's what I have domain expertise in, is pulmonary nodules and interventional pulmonology. If you look at this curve, this represents all outpatient visits. And all outpatient visits, you can see that they get diverted up to, we put 80% starting, right about April 4th, and then going on at least until April 23rd, in which the diversion rate may decrease as outpatient offices start to understand throughput and have the ability to see patients face to face. But as you can see, this red line shows the number of patients that are having diverted office visits. And we estimate that close to 60 million patients will have office visits that are diverted because of COVID. And of those, we think that approximately 11 million are essential patients, in which, if they continue to be diverted, may have some adverse outcomes. And so really what we want to focus on is, how do we have hospitals get back to what they're meant to do, which is patient care, and do that safely. Not only do we need to take care of COVID patients and protect staff, medical personnel, everybody in the hospital, but also protect the patient who is essential, that needs to be seen in a hospital. And we also did the same for outpatient procedures. And these are ambulatory procedures, level 1 through level 5, in terms of the diversion that we're going to see. And also, and if we talk about this just a little bit, a patient who needs to be seen, these procedures aren't going away. The need for the procedures isn't going away. So there's a backlog of these procedures that's happening. And what we're assuming is that hospitals will end up having the ability to get back to 100% efficiency by June, we hope. But quite frankly, there needs to be a definitive focus on standard operating procedures for hospitals to be able to get back to that type of efficiency and handle the backlog. And so, if you can see, every single day here, we are looking at different mechanisms that we can do to improve efficiency and also identify this group that lives within this green bar here and below. That's representative of essential patients that need to be seen. And so what we did too is we looked at what's happening with hospitals is that revenue is decreasing. And so if you look at the outpatient revenue that's missed, obviously there's a peak that comes in May, and recovery of that revenue, and also the importance of capturing the essential patients clinically in terms of the clinical value to the patient to decrease suffering and also mortality rates, is important for us to all become more efficient in what Mark Cuban is calling America 2.0. And so in our America 2.0, what we see is a concerted effort to identify different service line patients, and also to triage those patients in a way that allows us to see the patients that need either an office visit, a procedure, even if they need to have a procedure that will require an inpatient. Well, let's identify where we can actually do that. And the way you would do that is that you overlay the COVID curve in terms of hospitalizations and ICU visits, and you find out regionally where you can end up seeing certain patients safely. So that if a patient has 40% capacity, or they're at 60% capacity with 40% in their ICU, then they have the ability to do a procedure which may land a patient in the ICU or hospitalized for a thoracotomy or something of that nature. Another facility which is at 80% capacity already, or 90% capacity, obviously you would want to hold that procedure. So you need better information in terms of how to handle the second essential patient curve that was created by COVID, and rightfully so, right? So I think that the hospitals now are starting to get hold of procedures for handling COVID patients safely. And obviously there's some hotspots where PPE is still an issue, throughput is still an issue, but hospitals are starting to work that out. And we need to start thinking about how we are going to restart our healthcare engine. And to us, it's really through what we are calling safety net. And so safety net, what it does is that it identifies patients that have abnormal findings that need follow-up, specifically starting with radiological findings like an aortic aneurysm, like patients who have pancreatic cysts, pulmonary nodules that may be cancer patients. We're also talking about patients who, heart attacks are still happening. Heart attacks still need to be seen. But how can we safely get these patients in, and how can we identify them? So that's the problem. And every single day, what we're going to end up doing is we're going to be talking about different standard operating procedures. We have operating procedures for how to get, mobile radiology units up and going again safely. How do you get an outpatient radiology department up and going safely? How do you get a service line for pulmonary nodules up and going safely? How do you do bronchoscopy safely? How do you do colonoscopy safely? So all these things need to be handled in an efficient manner. And what we've been doing over the past 3 weeks is really jump-starting the pulmonary nodule service line. And for that service line, our recommendation and what we've seen with clients is that if you're for lung cancer screening, obviously putting off annuals and baselines for now makes sense. We do think that restarting annuals and baselines safely with a standard operating procedure is something that could be done in the very near future. But making sure that 3s and 4s, LungRads 3s and LungRads 4A, B, and X's get their follow-up that's needed to diagnose cancer now as opposed to waiting 2 months is something that's important. Now, obviously, with your particular facility, you would need to do a regional analysis of the risk of COVID and whether or not you have standard operating procedures in place. And if you don't, you can definitely holler at us and we can help you out with some SOPs so that you can get that going again safely. But we recommend that 3s and 4s at a minimum, try to get them in. And sometimes patients always, it's the same problem that, I think Mark was talking about with restaurants, right? Like, how do restaurants restart? How do you make patrons feel safe to sit in a restaurant again, right? And so we need to figure out how to make our patients safe again too. I need to feel safe as a doctor walking into a hospital. Think about a patient with the information that's being sent to them. They need to feel confident, one, that we've done a risk stratification that, listen, if you don't get if you don't get seen now, right, there's a potential for increased morbidity and mortality if we wait 60 days, right? And then two is that, listen, you could come to our hospital and you could be seen safely because here's our standard operating procedure to ensure that you don't get exposed to COVID personnel, COVID positive personnel, other COVID patients, or equipment that has been exposed to COVID. And so, hospitals have been in the business of doing procedures safely for many, many years. And we have high reliable organizations that have the ability to do that. And so one of the things that we need to get to is that we need to get to seeing patients again and doing patient care. Every single day, what we're going to end up doing is we're going to little tidbits. We're going to have guests on this live broadcast where other physicians, other nurses, other coordinators talking about some of the difficulties to pragmatically restart the healthcare engine. I'm looking forward to having a webinar next Wednesday as well. You guys can check out everything that's going on with EON, with Safety Net that we've already started with all of our current clients. Also, we have a big program that's going to go till May 30th in which over 4,000 hospitals can sign up for Safety Net at no charge for 2020, no risk. And if you wish to discontinue at the end of the year, there'll be no charge to your hospital. And we can identify your essential patients, starting with pulmonary nodules and extending that to at least kidney, liver, aortic aneurysms, pancreatic cysts, and others as we move forward. We'd definitely like to help out hospitals as much as we can. If you would like to be a guest on this broadcast, just DM me or hit us up at Eon Health. There is a little intercom button at the bottom right of our website. Would love to have you guys on. And then last thing is that we'd like to wish everybody a happy Easter. I ended up getting that rainbow surprise doll, which I caved in, and I'm calling that the COVID-related expense at my household. But I wish everybody a happy Easter. Stay safe, stay distant, and we'll talk to you guys again on Monday.